University of California. She's the head there, and this is the fourth event which we are attending here in Delhi in this hotel. I think we are really honored to have our chairpersons with us today, Dr. Bedi, Dr. Anmol, who are part of this event with us. Also, I would like to take an opportunity to welcome all the doctors who have joined from other remote locations. So we'll be asking them questions once we start with the panel discussion. And I think before we start the proceedings, I would like to invite our chairpersons, Dr. Nancy, to join us for the lamp lighting ceremony, marking the auspicious beginning of today's event. Yeah.
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परं ब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परं ब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश पतिं स्वच्छां हि मे सदा तवेरस्तं समारभ्य तावत् सूर्योदयं भवेत् तवेरस्तं समारभ्य तावत् सूर्योदयो भवेत् यस्य विस्मृते दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
शेयर करना पड़ेगा ना
ये वाला है ना
ये वाला है, हाँ।
Okay. Thank you, Vivek, and thank you, Chairperson Dr. Nancy. Thank you so much. So good afternoon, distinguished guests. It's both my pleasure and an honor to welcome you all to this Joint and Mobility Conclave. As we gather here today to share knowledge, learning, and spark new ideas, explore frontiers of science, it's only fitting that we begin by introducing the distinguished chairperson and speaker for today's event. Although, both Dr. Gurinder Bedi and Dr. Anmol are very well known and, respected orthopedic surgeon across the country and even, across the globe. Maybe I'll just introduce them with few words. Dr. Bedi is Senior Consultant, Orthopedic Surgeon, currently HOD Orthopedic Department at Fortis. And Dr. Anmol Maria, Senior Consultant, Orthopedic and Joint Replacement, Sama Hospital, New Delhi. And our international speaker, Dr. Nancy Lane. She is a distinguished professor of medicine and rheumatology, UC Davis School of Medicine, California. Also professor of medicine and rheumatology, Stanford Medical School. So before I invite Dr. Nancy, just to set some context, share some data point, and provoke some thought on how osteoarthritis affect India and globally, I'll just share some data points with you all. So if you see global burden of osteoarthritis, so global burden of osteoarthritis, and this is data from last 3 decades, globally around 595 million sufferers of OA. Last 3 decades increase in around 132.2% cases. So from 1990 to 2020, the cases have increased 132.2 percentage points. Projected to increase further. So if you look at different types of affection of joints, so 74.9% of knee, 48.6% of hand osteoarthritis, and 78.6% of hip osteoarthritis. And for other types of osteoarthritis, 95.1%. So this is the projected increase in OA, that too by 2050. Now for all age more than 70 years, OA is ranked as the 7th most common cause of years lived with disability. And as you could see in this pictures on your right, it affects all the part of the globe. Prevalence being at some countries more than others, but affect across the globe. And the trends, prevalence are on rise. Not changing the slide. Can you just help me with the slide? It's not changing. Okay, so what about India? So this is the data from India. So the burden in India, that too from the last 3 decades, osteoarthritis affect around 22 to 39% of Indian population and is a serious public health concern. So over the last 3 decades, the burden has increased from 23.4 million to somewhere around 62.3 million for a period in 1990 to 2019. So if you see the geographical representation, so it affects almost all of India, with some states having higher prevalence than other. However, the number of individuals with OA or the trend is only on rise. So we are still a young population, and as we the mean age increases, the incidence is likely to increase more. So on severity, so if you see 47% of Indian have mild OA, whereas 35.9 have moderate, and somewhere around 17.1% have severe OA. In all age groups, the age standardized prevalence of OA is higher among women as compared to men. So approximately 40% of population aged more than 70 years show OA, in which nearly 2% have severe pain and disability. So incidence increased by tenfold among ages from 30 to 65 years. And as expected, the contributing risk factor are obesity, increasing age, gender, educational background, and certain occupation which carry higher risk of OA. Now, not talking about in detail of what is the cost of disability. So obviously, pharmacological management, surgery, intangible costs in terms of pain, decreased quality of life, indirect costs in terms of absenteeism and reduced employment, etc. But just to give you some values in terms of how much the medical management costs. So somewhere around 20,000 Indian rupees is the cost of total direct and indirect medical management of OA. And on the surgical side, the cost varies from 1 to 5 lakhs in India. So what are the strategies for management of OA? So strategies revolve around, reducing pain and discomfort, maintaining joint stability and avoiding functional loss. And then, we have plethora of options available from pharmacological, which include NSAID, COX inhibitor, DOMADs, then intra-articular injection, corticosteroid, hyaluronic acid. We also have alternative therapies, which include herbs as well, Ayurveda, homeopathy, non-pharmacological management, which remains the initial therapy and part of the management per se, but also food supplements, so like chondroitin, glucosamine, omega vitamins, and now newer therapies like UC2. There are certain futuristic approaches like laser, etc., which are also coming into play. So this is just an overview of various global guidelines and, for various therapies, what are the recommendation. The darkest green are the strongest, level of evidence and recommendation, whereas the brighter red are strongly against use. So oral NSAID, topical NSAID remains, across all guidelines as the mainstay, including intra-articular corticosteroid. Uh, Majority of the guideline also recommend use of acetaminophen, paracetamol, which is less than 4 gram per day. Some of the guidelines are for and against as well for glucosamine, chondroitin, topical capsaicin, opioids. Not, I think, is not recommended by any, and intra-articular hyaluronic acid as well. Recommended by some of these guidelines. However, there are certain changes which are also being coming into the practice. Now this is a recent publication from International Journal of Orthopaedic Rheumatology, wherein a stepwise approach in management of osteoarthritis is being recommended. And in this paracetamol along with undenatured type 2 collagen is one of the initial management option along with NSAID. And as the disease progresses, the stepwise management approach is being recommended, which include NSAID, defining on the risk factor, etc., to as a step-up approach is being recommended. So what is UC2? So UC2 is undenatured type 2 collagen. The unique nuance about undenatured type 2 collagen is that it has a triple helix structure. The structural integrity of collagen remains intact, which is what is responsible for the antigenic effect and stimulation of T regulator cell, which Dr. Nancy will dwell in detail. So the important point is that the extraction process of undenatured type 2 collagen is patented by Lonza, and we source it from US. Their manufacturing site in US, and so the triple helix structure and the epitope structure remains intact, which is what leads to the antigenic effect in the Peyer's patches, which stimulates the T regulator cell and the anti-inflammatory response known to UC2. The structural integrity is also what prevents it from denaturation in the stomach and prevents from the gastric acid. So not all collagen are same. So different type of collagen have different characteristics. So molecular structure of collagen determines its mechanism of action. The denaturation process actually disrupts the molecular structure, which I just shared with you. Undenatured type 2 collagen preserves the original structure, and it preserves the cross linkage, it preserves the collagen triple helix and the epitopes, which are responsible for the antigenic effect. So different type of collagen, like soluble native collagen, will not have cross linkage, and the mechanism is different. It does not induce antigenic effect, and hence the stimulation of Treg cells does not happen. So just to differentiate that, so this is from electron microscopes to see that, does the extraction process changes the structural integrity of collagen. And the slide on the left of your side is from UC2 and showing the intact triple helix structure which is maintained, whereas the one on the right, the triple helix structure is kind of destroyed during the extraction process, and hence the potency of collagen tends to reduce. So in terms of comparative requirement, UC2 need to elicit the same antigenic response is much lower. So denatured collagen is required 1.5 to 6 times for as compared to UC2 for the covalent and other denatured collagen type 2. So this is just to introduce you Centrum joints and mobility. So this is a combination of UC2 collagen, which is 40 mg, along with vitamin K2 MK7, which is 55 mcg, vitamin D3 600 IU, calcium 150 mg, zinc, manganese, and copper in combination as once daily dose. So just a few points on vitamin K2. So we all know that vitamin K2 MK7 is required for calcification of bone. There is data to support use of minaquinone 7 in postmenopausal women, wherein with use of MK7, the BMD parameter tend to improve. It is also microencapsulated, which reduces the chances of arterial deposition, and it has long half-life, which is suitable for once daily use. So that's in from my end. May I invite Dr. Nancy for her presentation, please? It's a different one.
Yeah, I'm used to this one. Okay. Very good. There you go. You got it? Not quite. There we go. Well, good morning. Happy Easter. And it's wonderful to see you all here this morning. And now I'm going to take you on a journey to tell you about osteoarthritis with the focus on UC2 undenatured type 2 collagen. Okay. Now, to start with, I'd like to do a quote that is often said: if there's an illness of which people offer many remedies, you can be sure that particular illness is incurable. And I'd like to say that sometimes, unfortunately, we often think about that with osteoarthritis. Now, how do we manage osteoarthritis today? I think as a rheumatologist, I start at the bottom of this pyramid with non-pharmacologic therapies, first educating the patient about what the disease is, getting them some physical therapy, getting them to do some type of exercise. And then as the disease progresses, we give them acetaminophen, nutritional supplements. As the disease progresses, we give them nonsteroidal anti-inflammatories, orals and topicals, including COX-2s, eventually opioids, unfortunately, eventually surgery. But along that journey, we often give intra-articular steroids and hyaluronan as needed by the patient. Now, what got me into the nutraceutical area of study was when I was asked by the NIH to participate in a study of glucosamine and chondroitin sulfate for the treatment of painful knee osteoarthritis. Now, this was a very big study. It was done throughout the United States, and the results were published in the New England Journal of Medicine, which means we had a very important finding in clinical medicine. How did we do this study? Well, we randomized about 1,500 plus patients to a number of different treatment groups: placebo, glucosamine, chondroitin alone, chondroitin with glucosamine, and Celebrex. And what we found was actually surprising to all of us, that the glucosamine and chondroitin sulfate, either alone or in combination, was not different than placebo. And the only medication that actually had an effect in these knee OA patients was, at 4 weeks, the Celebrex. So we started to scratch our heads. This glucosamine and chondroitin wasn't doing the job. Let's take a deeper dive and understand a little bit more about cartilage and osteoarthritis. Now, I know this is a little bit of a simplified picture, but I wanted to just remind everybody a little bit about cartilage. Cartilage is a fascinating material. It's like a sponge. When we put weight on our cartilage of the knee, the water goes out, and when we take weight off it, the water goes back in. And why does that happen? Because we have a wonderful backbone of collagen. We have the proteoglycans that send the water in and out. And we also have water that sits within that tissue. Now, chondrocytes are the only cell that sits in the cartilage, and these are amazing cells. I don't have all day to talk to you about them, but these cells, through different signals, both make the cartilage matrix it sits in and actually resorbs it or breaks it down at the same time. So it gets certain signals, it breaks down the cartilage, different signals, it builds it back up again. It's a wonderful process, especially when it's well balanced. What happens though? And I want to make sure I mention that articular cartilage has a couple different collagens in it. It doesn't have collagen type 1, that's for the bone, but it has collagen 2, collagen 9, collagen 10, collagen 11, and that's what gives cartilage its wonderful backbone. Okay, but what's osteoarthritis? Well, again, it's complicated, but I think we'd all agree that somewhere along the line, there's mechanical forces that, for example, are experienced by the knee. The cartilage breaks down, it releases molecules that set up an inflammatory pathway that then go back and destroy the cartilage. And in that, there is a little bit of an immune response, which gets that whole inflammatory process going. So let's focus a little bit on T cells. T cells are very important for the effector part of the immune system that tell the other cells to do what they're supposed to. We have a couple different T cells. This is a little bit simplified, but go with me for today. Th1 cells are pro-inflammatory. They increase the whole process of inflammation. But we have other types of T cells, Th2 and Treg cells. And these T cells are anti-inflammatory. Now, what do I mean by that? The Th1 cells make interferon that activates the immune system. Th2 and Tregs make anti-inflammatory cytokines, IL-4, IL-10, TGF-beta. So now, what's the mechanism of UC2, undenatured type 2 collagen? Well, what we believe is the mechanism is the following. You take the medication, goes into your GI tract, it gets broken down, absorbed into the lymphoid system that sits right, let's see if I've got, that sits right beneath the cells of the GI tract. It processes the molecule, it activates Treg cells, which then go on to make the anti-inflammatory cytokines that potentially will reduce the pain and inflammation of the knee. Now, this process is slow. It doesn't happen overnight, but it does appear to be reasonable. So you take the UC2, gets absorbed through the GI tract, goes through the lymphoid system, then activates Treg cells, which generate anti-inflammatory cytokines. Okay, so how do we know that this might be the mechanism? Well, let's tell you about a study that we did a number of years ago, looking at the oral undenatured type 2 collagen, looking at it in a rat model of osteoarthritis. Now, for this model, there's no perfect osteoarthritis model in a rodent, but this one isn't too bad. You make a lesion, you cut out the medial meniscus, and that starts cartilage, or part of it, and that starts cartilage deterioration. And what we did was we took rats and we left one group alone, and another group we made the lesion, and another group we made the lesion, and we gave UC2. And what did we see at the end of 8 weeks was pretty interesting. When you looked at the rear right leg in terms of weight bearing, this is your not treated, and then your placebo. But then if you got UC2, the animals could put more weight on that joint. And then when you looked at the histology, this is the native one. This is the and then when you looked at the one that had no treatment, you see more cartilage deterioration, a little bit less with the UC2. And the bone beneath that joint was well preserved with the UC2, looked very similar to the native. So that was a suggestion that there was some activity of this molecule in an injury model like osteoarthritis. So let's let's review again what UC2 is. It's undenatured, it's native type 2 collagen. The source is animal. We can talk about that a little bit later related to particular diets. However, it's different in some ways. UC2 that we're talking about, undenatured type 2 collagen, it's the intact structure. It's recognized by the body. And as I'll show you, there's some oral tolerance that it appears to be able to achieve. However, denatured type 2 collagen, the structure is destroyed. It's not intact. We believe it's not recognized by the body, and there's no evidence yet of oral tolerance. So these two are very, very different, and probably like you to think about that. Okay. Now, the study that got me very interested in this collagen was a study done many years ago at Harvard by David Trentham, who's a rheumatologist, now retired, and published in the journal Science. Now, those of you that publish papers or read them know that Science is one of the best journals we have where new, exciting science is actually published. So when something gets published in Science, you read it and you think about it. Well, let me show you what Dr. Trentham and his group did. This was before biologics, if you can believe it. And they took a group of patients with rheumatoid arthritis, 60 patients with rheumatoid arthritis that was active and what we would have called severe. And they took them off all their immunosuppressive drugs. And then they randomized them for 3 months treatment with either placebo or oral denatured chicken collagen. And what they did was they gave one dose for a month, 0.1 milligram per day, and then they increased it to 0.5 milligram per day for another 2 months. Now, let's look at these patients. What were they like? They were about 50 to 55 years of age. They'd had 10 years of disease. They were rheumatoid factor positive. Many of them were on prednisone, and many of them were on immunosuppressive agents. So they had very active disease. So what happened? Well, if you follow this slide with me, you'll see, look at the baseline, the UCC versus placebo. The number of tender swollen joints was about 12. And in the collagen group, they went down by 3. If you looked at tender joints, there were about 15, and you had 5 less, went down to 10 with the undenatured collagen, no change in placebo. Morning stiffness went from 103 hours almost just to 50 minutes. So from 3 hours to 1 minute. The patients, how they thought they improved, they went up. And the last measurement I'll show you is the sedimentation rate. Very cheap way of measuring systemic inflammation. Went from 39 down to about 2. So again, tremendous difference in disease activity and measures of inflammation in patients with active rheumatoid arthritis. That was a very defining study. So now I'm going to leave rheumatoid arthritis for a couple of reasons. One is because we have biologics now, lots of them, that we use for rheumatoid arthritis, and that is a disease without an unmet need at this moment. And let's talk about osteoarthritis and what's been done, and joint pain, and what's been done with UC2 over the last few years. In the past, say 10 years, there have been many studies done, 4 in healthy subjects, 12 in OA subjects, compared to glucosamine and chondroitin, a couple. Over 2,000 patients have actually been studied, age range 20 to 79. And I think I'm going to show you some of those to give you a sense of the efficacy of this compound. The first study that I'm going to talk to you about was actually done in relatively healthy volunteers who had knee pain from over-exercising at the gym, which we see often in the United States. It's called gym disease, okay, or too much free time disease, one or the other. Anyway, they studied 55 patients who had knee pain, mostly from over-exercise discomfort. They had to have a certain amount of it. There were both males and females, about 46 years of age, and they were randomized to placebo or UC2. And what happened, and this is going to be a theme that I'd like you to follow as I go through these studies, is nothing happened too much between placebo and the UC2, say in the first 7 to 20 days. But after 30 days of UC2, you see continuous out to 120 days improvement in the range of motion of the knee. In addition, you also see improvement after about 30 days compared to placebo in the WOMAC score. Now, the WOMAC score is a measurement that we use in osteoarthritis all the time, but it's three things that you need to stay with me on this. It measures pain, it measures stiffness, and it measures joint discomfort doing your activities of daily living. It's a combined score. And what you see here, or a function score, is that again, as you go out to 30 days and then on out, patients with knee discomfort from overuse injuries continue to improve. And one of the outcome measures they used in this study was stair climbing, going up and down stairs. And the time it took to get new knee pain on the UC2 was actually took a lot longer if they'd been on UC2 versus placebo. So there you go. That was that was actually a surprising result. And then again, time to minimal joint discomfort, it became much greater with the UC2 than the placebo group, and consistent, as I'll show you with other studies. Okay, well, those patients did not have osteoarthritis. They had knee discomfort, probably tendonitis, maybe patellar disease. But what about in osteoarthritis patients, something that we see a lot in our practices? Well, one of the first studies that was actually done here in India to look at undenatured type 2 collagen in the treatment of knee OA. Now, in this study, it was small, about 50 subjects or so, about 60 years of age, and they were about 50% females and males, and about 50% of each right or left knee were involved. What did they find? They looked at total WOMAC score. And again, the theme starts to come out, not much until about day 30, you start to see that the subjects on UC2 have significant improvement, and they continue it out to 90 days. They don't lose the effect. Okay. Now, I became involved in another study of UC2, and this was larger. It was multi-center. It was double-blind, placebo-controlled against glucosamine and chondroitin. What did we see? Well, first of all, as I mentioned, we had 3 study groups. We had about 60 patients per group. We looked at the primary endpoint was total WOMAC, and we had secondary endpoints. And we had 13 clinics that participated here in India. Now, what I'm showing you here is the result of the total WOMAC score. And this is an important theme. As you see, everybody starts with pretty high WOMAC score. High score is bad. And then at 30 days, you don't see much difference. But as you go out 60, 90, 120, 180 days, you see that the UC2 separates and significantly different from both placebo and glucosamine. And this, to me, was the first study that said, okay, this is doing something. Now, let's leave India and let's move over to Brazil, okay? Because you say, okay, is this just good for Indian patients, or could this be used other places? And so let's look at some Latino patients, and it's a similar study was done in Brazil, although they only had 2 groups. They had a UC2 group and they had a placebo, no UC2 group, about 50 subjects per treatment arm, and similar outcomes. What did they see? And they only went out for 90 days. But if you look at the change in UC2 versus control, it was significant for the VAS pain scale. Look at that at 90 days. It's 50% less. You look at SF12, which is a measurement not so much about knee OA, but how you're feeling in your physical activities. Again, dramatic improvement in your daily activities with UC2, and WOMAC also was significantly down, showing less pain, less stiffness, etc., both in the treated group. Now, one of the last studies I'm going to show you is actually, or second to the last study I'm going to show you, is actually a little bit different. It's a small study of only 40 subjects, 20 randomized to UC2, 20 randomized to glucosamine and chondroitin. And what I liked about this study, and I'm sorry that it's so much data in one slide, but it compares, it breaks down the WOMAC into the different things we measure, and you can actually see where the improvements are. So you can see after 90 days, you had less pain walking with the UC2 than glucosamine, less pain climbing up and down stairs, less night pain, less pain on weight bearing, less stiffness, and functional parameters also significantly better. So when you look at it as a total or you look at it apart, it appears to be better. Now, you could say that I've shown you a lot of data from India, some data from Brazil, but what about looking a little more globally, if you will, or half globally across Asian descent? And this isn't a very sophisticated study, but it's looking basically at just Asian patients, looking at 90 days, about 100 patients, 50 per group. And when you look at UC2 versus placebo, again, the same thing. You don't see much until about day 30, and then, oops, it really changes significantly from placebo, both in total WOMAC and in VAS pain scale. So there's a lot of consistency in this data. So how do I put this together? I think for UC2, Undenatured type 2 collagen, it's a once daily dose. The mechanism, at least as best as we know now, is anti-inflammatory signals in the joint through upregulating the anti-inflammatory T cells. What's its effect? It reduces the joint pain, stiffness, and improves function in patients, and this is important, with mild to moderate knee OA or just knee pain, but not severe OA. UC2's efficacy is observed across different ethnic groups, and at this point, there's no apparent safety signals with the oral ingestion of UC2. And that's my presentation. Thank you very much.
Thank you so much, Dr. Lane.
Where are we going to do?
Yeah, I'll invite you as well as our chairperson on the dais. Just allow us a minute for them to put the chairs. So, sir, we also have 5 locations who have joined live. So these are Chennai, Kanpur, Ranchi, Chandigarh, and Bhubaneswar. So we'll invite questions from those locations, and obviously we'll allow the audience present here to ask questions. Yeah, we'll mic for all of them, please.
The green light is on. Don't appear.
Closer to your mouth, please. All of us can listen.
I think
Okay.
you're a soft-spoken lady.
So maybe we go with the audience here. Sir, whatever.
Okay. So, Nancy, that's a hell of a lot of information thrown in. So, and thank you so much. Thank you so much for dropping into India. I know you've had a whirlwind tour. You've been to 4 cities already, and you still haven't seen Connaught Place, which we're hoping you will see tomorrow when it's open. But more importantly, I mean, awesome amount of information, and good to see that you're one of the original researchers on undenatured collagen. So this country, I think pretty much as you've gone through India, you realize is actually, I mean, Indians love nutritional supplements like nobody else. So one thing we don't want to do is keep going to doctors. And the other thing we hate doing is getting an operation done. So the desperation to avoid an operation is actually huge. So, and if you just keep telling them, look, you know, please do your physiotherapy, please take your paracetamols and anti-inflammatories, it really doesn't do well. I mean, people like the idea of, look, isn't there something that I can take, which I can just have and not see you again, kind of an attitude is very, very common. So something that people love the idea is something to eat. So Indians have always thought that the way to good health is actually from the stomach. I think the biosomes is something proving what we thought was always wrong, but maybe the stomach is the place where everything seems to be happening in this country. So we have a fairly good mix of people out here. There are physicians, there are rheumatologists, there are orthopedic surgeons. So hopefully we'll generate some amount of discussion on this. So I think we'll start off by, we're also, as you know, getting questions from across, across 5 cities. So we can keep taking the questions and this alongside. Guys,
please raise your hand. We'll bring mic to you, and then you can just introduce yourself and ask your question, please.
Hello, that was a nice lecture. I am Dr. Chauhan from Delhi. I'm a physician. What is the role of these DMARDs, especially methotrexate?
The question is, what is the dose of a DMARD like methotrexate for osteoarthritis?
And is there a role for,
Well, yeah.
if you believe that
Question is
that
role,
osteoarthritis,
because there was a
Yeah,
recent
so-
study
Recent
published in,
information.
there was a recent study published in NEJM.
Oh, I know, I
And
know.
where exactly do you place them? And do you do anything?
Oh, wait a minute. The recent study on methotrexate in the New England Journal?
Yes, I think so.
Okay, because there's going to be one coming out, if it's not already out, in JAMA Internal Medicine, and a similar study I wrote an editorial on. So I will tell you, when it comes to the knee, we really don't have data to suggest it helps in the knee, in the knee. However, Nature Medicine had presented a good study. No, I forget. Lancet, I can't remember. Anyway, Lancet showed that there was efficacy of methotrexate for hand osteoarthritis. The dose they used, I believe, was similar to RA at 20 milligrams a week, or 15 to 20 milligrams a week. I want to spend time as to why methotrexate probably doesn't work in the knee. And that is because methotrexate is really good when you have a lot of cells turning over, like in rheumatoid arthritis. But cell proliferation is not that great in osteoarthritis. Okay, and so I think it just doesn't have enough efficacy. But in the hand, when our patients get hand OA, they have a lot of bone turnover. And I think methotrexate's always been known to slow bone turnover, slow bone formation. And I think that two things. Methotrexate reduces bone formation because it reduces osteogenesis. We've known that for a long time from cancer. Plus, the nerve cells grow in through the bone. And so if you're stopping bone growth, you'll stop nerve growth. And that's probably why it works in the hand, but not the knee. And if you were going to try methotrexate, I'll just sort of start to say this as we go on in our discussion today, which is, by the way, great question to start it off with, is that's a patient that I would also give UC2 and maybe add methotrexate to, because I'll coming back to, as long as it's not severe OA, UC2 may have a role. Okay.
Okay, another question.
Just a minute, Gurinder, 1 second. As an add-on, when you said hand away, were you referring to carpo metacarpal joint or the distal
no,
interphalangeal?
Very good. Discussing the
Interphalangeal.
IP
PIP
joint.
SAC.
Okay, that's important to note because the carpo
Yes,
metacarpal
yes.
behaves very much like the knee. Because very often we come across patients just carpo metacarpal and the knee, no other joints by and large, at least in India.
True.
Yeah.
That's pretty much a mechanical kind of an overuse kind of a thing. which will happen.
Right.
So-
Exactly. Thank you.
I'm Ramakant. I'm a practicing orthopedic surgeon.
Hello.
You haven't done
Uh,
one year back. Lot of patients. Then we started. You're all me. Have you any?
We're using as
Sir, no. Yeah, I'll just what he's saying, type 1 collagen versus type UCII. Are there narrative? So basically, other type of
not aware. A lot of different. Osteoarthritis. Right. I don't think.
So the
Hello?
is the molecular it's the molecular which stops the oral mechanism. Molecular stuff in all of the collagen, whether it's a high-class collagen, whether it's a collagen peptide, not similar to all native collagen. So actually, if you believe in the modulator response of collagen, it will be pretty much happen in a UCI. Is there any other collagen? I mean, how do you any other collagen. Because we have actually got a lot of freely available same kind of stuff. As supplements, is there a role for why more role? That's the question.
You gotta roll, you gotta do the models. UC2, there's a theoretic, the immune modulation, but then when we put it into the rat model of joint injury, it actually had an effect. And then when you put it into rheumatoid arthritis patients, you actually saw reduction in inflammation. So, maybe the other collagens might work, but you've got to study them. And I don't think they're studied it that way.
Why is it that no study has been done? Is there a reason, or is it just not worth doing that study, in your opinion?
Well, for example, collagen 1 wouldn't matter because I don't know, it's a really good question. I don't know. I mean, I suspect there's a lot lots of collagen have been tried, and maybe they haven't had an efficacy in the preclinical models. They haven't been taken through.
I'm Dr. Manisha Agrawal from Kanpur.
Okay.
A very good afternoon to you.
Any other? Yeah.
Thanks,
Can you
ma'am.
please bring the mic?
Uh,
So please
thanks, ma'am.
announce your
Hello.
name and then please feel free to ask.
I'm Dr.
We are
Manisha
receiving few
Agrawal.
questions from the site as well. Maybe we'll go live, allow them to ask.
Hello.
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 Yeah, I'm Dr. Manish from Delhi. My simple question is, any vegetarian source for UC2? We are primarily a vegetarian country. Most of the patients do ask for green, not for UC2 products.
So the same question, Dr. Lane.
Oh, that's a great question. Unfortunately, there's no vegetarian source of UC2. That said, even in California, we have a few vegetarians. And one of the things that we discuss is if the pain is significant enough, some of my vegetarians do try it, but it's not vegetarian. And at this moment, I don't know of a pure vegetarian collagen too. It's a good question.
Thank you, ma'am. One more simple question. Native collagen and UC2 are the same, or they are different terminologies for the same product?
Well,
UC2 and native collagen.
Okay. So the question you want me to answer? Yeah.
Carry on.
Okay. So the question is that native collagen versus UC2. So the term native actually is used when the collagen structure remains intact. So the triple helix structure should remain intact, and that's what we call as native collagen. However, in our market, and Dr. Nancy also showed you a comparative study, and I also tried to show you a comparative study. Although some of the available formulation are called native, but they are not so native because the extraction process of collagen, either using heat or using chemical, tend to destroy the native structure. So although they are called native, but the percentage of them having retained the original triple helix is a question mark. However, for us, since we source it from Lonza, which is a site based in US, and that's the only site location where UC2 is made. So we do maintain that quality standard, which are followed by US FDA, etc.
Thank you so much.
Yeah, and just to highlight the importance that if the native structure is lost, then the whole mechanism of action is lost, because then there is no epitope, there is no pair patches stimulation, there is no Treg stimulation, and those interleukins, etc. So that is the importance of maintaining the structure.
Nancy, can I ask you on the vegetarian thing? I mean, I think in your years of research, we get a lot of vegetarian sources like boswellia, curcumin and all. Are you aware of anything which you think is sort of something showing? I know there is no sort of great answer in terms of evidence-based practice. Any one of them which you have a liking for, in the hope that there will be a good vegetarian source for a population?
That's a great question. Any nutraceuticals that are vegetarian? I think the cumin and I think bee pollen, but we just don't have, and turmeric, but and I think I would try them. And there are patients who respond to them, and they are vegetarian. But
So we haven't got a good research going on this. No, right, okay. Dr.
No.
Yes,
Dr.
sir,
Bedi,
please.
Dr. Maria, I have a very simple question to ask. Some companies are coming with UC2 in 20 milligram, and this is Centrum joint has 40 milligram.
Yeah.
So it is advisable to give one morning, one evening, twice a day, or single dose at the lunchtime.
it's once a day, and you know what I tell my patients with UC2 or anything else, it's once a day. You take it at the same time. So if it works out in the morning, take it in the morning. Works out at noon, just regular, try to just put it into your routine.
Yeah.
It doesn't matter. There's no diurnal, to my knowledge, there's no diurnal variation in relationship to its effect on and its immune modulation that I'm aware of. So the time of day doesn't matter as much as it just is taken every
Yeah.
day.
Just to add, sir, the available evidence and the data and the formulation available globally also, all are 40 mg, and it's recommended to be taken once daily.
Is it true that patient compliance with nutraceutical market is actually more with the once a day dosing rather than twice a day? People actually like the idea of taking it in the morning and getting done.
That's right.
As a general thing, which has been seen is patients don't like the evening medication unless it's a hypertensive or something, it's something else. But most people, at least in my practice, Anmol would say, are much happier of once a day, take it in the morning, done, don't come back to it for the rest of the day.
Basic human nature, I suppose.
Yes.
And one more thing, you said there's only one authentic source of UC2. Did you say that?
So, sir, the manufacturer for UC2 and the brand UC2 with registered comes from Lonza. Lonza has only one site which manufactures UC2.
But we heard many pharmaceutical companies now coming up with UC2 in the combinations. So are they necessarily sourcing from the same source?
So if it is Lonza, they would have to write the capital UC and registered. So they might not be sourcing, so they might be using the abbreviation of undenatured collagen 2, mentioning it as UC2. So if you see our branding, it's a green color and there is registered trademark. So that brand name is registered by Lonza, who is the innovator for UC2. So unless they are sourcing it from UC2, they cannot use the brand, U capital C and the Roman 2 letter, because it's been patented by Lonza. So there might be other formulations which are not sourcing from the innovator, but they are mentioning it as undenatured collagen type 2.
What are the other sources beyond Lonza?
Sorry, sir?
Other sources of UC2?
Other manufacturers.
Other manufacturers.
Not,
so sources could be, say, for example, the one we use from Lonza is from chicken sternum. So there are other bovine sources as well, and other animal sources as well for extraction of collagen. So collagen, as of now, is being extracted from animal source. So chicken is the source for UC2 by Lonza. But there are other bovine sources as well. Sure, sir. Dr. Lee. So the question is how much for how long duration should we use UC2?
Well, I think that's a great question, because for those of us that treat osteoarthritis in the knee, if somebody comes in with mild to moderate disease, well, I've had patients that have been on this supplement for 10 years, but
At a stretch.
saying
Yeah, how much? How long?
at a stretch.
Or you can give a
Hang on.
break.
Hang on. The first thing I say to the patients when they decide to take it is that I want them to take it for 3 months to see if they have any improvement. If they don't have any improvement in 3 months, we may find a few more months, and if not, we stop it. But what I wanted to convey in my story here, in my review of the studies, is it's a slow onset of action, because it takes a while to kind of get the immune system organized into the anti-inflammatory, making the anti-inflammatory cytokines. So you really need to take it for 3 months, 6 months, get a sense whether it's helping. Now, if it's helping, patients can continue to take it as long as they think they want to. You know, I've had patients on it for many years. Now, you can say, okay, well, if they're on that and they have an increase in knee pain, I may treat that knee pain with an injection of steroids, an injection of hyaluronic acid, or give them NSAIDs for a few days, but I may continue the type 2 collagen for a period of time if they think that baseline is helping them. So if you treat rheumatoid arthritis patients, I'd say that this is a little bit like hydroxychloroquine. We know it helps and we keep patients on it, even though it's not dramatic, but this doesn't maybe change the course of the disease, but it definitely can reduce pain in some patients.
Any side effects other than indigestion?
Well, if they have any kind of reaction to the collagen, you would see it. I haven't seen anything in my using it over 10 years, but theoretically they could be responding, you know, having some adverse effects to the type 2 collagen because it's intact.
You have mentioned indigestion in your.
Anmol, I think, you know, side effects is a big issue in this country because even before you stop finishing the drug in your prescription, writing the drug, the first question that always comes is, what are the side effects? And I'm telling them, look, would you mind asking me the effects before you get to the side effects kind of stuff? So Anmol, you've seen a lot of people, you've been around for long years. Anything you've seen people with collagen coming back to you? Any problems, any issues?
Frankly, I haven't used collagen too much in my practice so far.
So I don't know why, but I mean, Anmol, I see a lot of people still complaining about bloating and some aftertaste and everything. I really can't understand it, but I mean, I'm sure I take it the question is coming because you've seen some similar kind of reactions from people, and I have no answers, but maybe Nancy can tell us more.
Well, I was going to say that, you know, that is the one thing that the patients have come back and said, you know, I think my GI tract's not quite working right. I say, okay, stop it for 2 weeks, see if it changes. 90% of the time, it's not the UC2, but you know, occasionally.
Could it be the combined calcium?
Yes.
Because you have combined calcium in it. Many people are not able to tolerate calcium, particularly if it's calcium carbonate. I do not know what particular salt of calcium you're using. Using
Right.
carbonate?
Yes.
Well, calcium carbonate does tend to cause a feeling of dyspepsia and bloating sensation. That is very common with calcium carbonate, and that's why we have to sometimes switch the salt of calcium in many patients to citrate maleate or citrate or something else.
Or we give them Tums, right.
So for that reason, only we have kept the calcium amount minimal. So it's only 150 mg because, you know, of the bloating side effect.
With the calcium, it does a little better if you take it with food too. So if,
Vitamins.
yeah, so if you have something in your GI tract, it appears to
So Chandigarh is
cause
also
less
waiting.
problems.
So if you allow, maybe we'll take some question from Chandigarh side because they're like waiting and asking. Just allow us a
1
minute.
minute.
Okay, so we go back to Chandigarh and please unmute yourself and ask your question.
Hello. Hello. Am I audible?
Yeah. Yes, sir. Please be a bit louder.
Yeah.
Go ahead, please.
All right. So this is Dr. Neeraj Gupta from Chandigarh. I'm moderating from Chandigarh side. So I have few questions. We have residents from PGI Chandigarh, which is the Premier Institute, and these young residents have few questions. So the first question is from Dr. Pavan from PGI. He says that since the mode of action of the collagen peptide, this is on the T cells, as Dr. Lane said, that the anti-inflammatory action is through the T cells, and the T cells do have a memory. So can we give it in a pulsatile dosage instead of a daily dosage? Is it possible, Dr. Lane?
I'll try to.
T cells have a memory. So what the thing is there a residual effect so you can make it more pulsatile?
It's a good question. The memory T cell piece of this has not been carefully studied. The TH2 and Tregs, you know, we're just starting to understand all the things that they respond to. But the answer is, I do not know. And your argument would be once the memory T cells get involved, you wouldn't have to give it as much. But I don't think that the effect is going to be at that depth. But I don't know. It's a good question.
All right. Thank you, Doctor. The second question would be from Dr. Manjunath from PGI. So the question is that how long can it be given? You have already told us that, but to add to that, supposing the patient can the patient take it for continuously 1 year? And do you recommend that if the patient says, I'm okay with this, I'm feeling better, so can we give it up to 1 year non-stop without any interruption in between?
Yes, you can give it. I've set up patients on it for 10 years. Yes. Now, but I would say it's important to, like, you don't want to give anything that the patient's not going to, be helped. So, at 6 months, if they're still having a lot of pain, they're not better, I may not continue it. But if they're doing well on it, then I continue it. It doesn't appear to lose its effect. So if they're responding, that's good. Now, you don't ever truly know if they're responding to the therapy or their knee just got a little better over time, which happens. But, I think it's got positive effects.
All right. And the last question would be that what is your experience of giving it using the UC2 in grade 3 and grade 4 OA? Because in your studies of India and Brazil, we could not understand that whether the UC2 was used in which grade of the OA. So we have in India most of the patients, they report to us quite late. They have good pain tolerance. So they sometimes come to us in grade 3 OA. So does it have any role in grade 3 and grade 4 osteoarthritis?
Well, I'm going to take a shot at that, and I'm going to ask my orthopedic friends here also to weigh in. There's the structure, the deterioration in the structure, and then there's the pain. You can have patients who have no pain, who have grade 3 knee-OA, and you can have those that have pain. I would say that I give it a try in patients with grade 3. If they come in with pain in grade 4, I don't, and see what happens. I've had some success in moderate knee-OA painful knee-OA by giving the UC2 and then giving a shot of glucocorticoids if needed, or hyaluronic acid, which stops a flare maybe, and then continuing it. But like any chronic disease, you have to monitor it and make adjustments.
Okay, so the way it works is, as I see it, so the best you can hope from a nutraceutical thing is preservation of the existing cartilage that you have. If you're in grade 3, grade 4, and you do a histological analysis, your chondrocytes are so much more less. Your collagen is already showing signs of degeneration. The matrix is all broken up. And the chances that you can make this preserve is not going to happen. So we are looking at something which will actually prevent further degradation. It's not forming cartilage. This is not a chondrocyte proliferation. This is not a biological therapy. This is much more the preservation therapy that we are talking about. The formation strategy is different. You can go with the idea if you have a belief on PRP, stem cells and all that, but your belief, this is actually not the same kind of a place. So you need to have some amount of normal collagen matrix, and you need to have your normal chondrocytes, which will actually make it survive rather than regenerate it. So as I see it, zero role in that advanced kind of a thing. I know patients will demand something, and just like you and I, just like your practice and my practice, I will write it up, but it comes with an undertone of saying, look, I'll do it if you want, but don't expect miracles. But the dictum is try it and see how it goes in the first 30, 40 days. And if you don't like it, you can stop it. If you see an improvement, carry on. Anmol, you have more experience.
On a lighter note, someone with grade 3 and 4, you said don't expect miracles. Grade 3, tell them to expect miracles.
Okay, that's a good point. Is it a miracle drug or not? Anmol, your take again. Sorry.
No, another thing I would like to add over there. By and large, in our practice, grade 1, they never reach the doctors. By the time generally they come to the orthopedic surgeons, they've been to the family physicians, they're already, by most of them are grade 3, grade 2 plus, grade 3.
That's right.
Huh?
That's right.
So now we are left with the challenge. They're coming to us at that stage. Is it worth prescribing UC2 at stage 3? Because after all, we are looking at preservation in terms of an anti-inflammatory response, preventing the breakdown enzymes.
I think that I agree with both of you. You have a grade 3, Kellgren Lawrence grade 3, moderately severe OA, and they've got pain and swelling. This is not going to change it. Maybe if they have no swelling, you're not much synovitis, might be okay, but no miracles. You're exactly right. This is not a miracle drug. That's right. It helps. It's got some anti-inflammatory effects, but it's not going to be a big player in the moderate to severe disease.
Is it available over the counter in the US?
Different, yeah, it is. It is. And many other different,
So
like.
just like
forms of it.
glucosamine and chondroitin, patients coming from the US with the big boxes, which they pick up from the departmental stores. You think that's going to be happening with UC2 somewhere down the line?
Probably.
Because after all, we're looking at stage 1 and 2. And by the time the patients generally reach the orthopedic surgeons, he would be in stage 3.
Yeah, I think the patient population that I'm seeing with it is the ones that have mild disease, who have some intermittent pain, and they take this continually and they decide whether it helps them or not.
You
But
did
it's
mention something about the young patients who go for regular gymming.
the gym, right?
The gym knee. I like the term, the gym knee. Huh? And so as a rheumatologist, do you have the gym knees coming to you and do you prescribe UC2 for them?
I do. I don't see many, but I enjoy seeing them. It's not too complicated, and I do, yes. They're the easy ones.
Yeah. So before we move on to Chennai, sir, please ask your question.
Since we are talking of grade 3 and 4, where is the role of maybe PRP therapy or this thing? Because that is considered to be the regenerative thing rather than preserving thing.
Well, PRP, platelet-rich plasma, is used in the United States. 90% of it is used by orthopedists, not very much at all by rheumatologists. Why is that? Because platelet-rich plasma is the patient's platelets that have been, removed from their blood and then injected in. And platelets have growth factors, so they can stimulate cartilage to grow, except when you have an adult. If you have an athlete who gets injured and you give them their PRP, there may be a little bit of regeneration of tissue. But if you take an osteoarthritis patient, you give them their platelets, nothing. So I don't give it. I have colleagues who give it, but I don't give it. I don't do it.
Well, Samarjit, since you raised the question, she doesn't use it. I have used the GFC a lot, a very large number of patients. I have been generally very happy with the feedback.
That is why I picked
Very
this
happy
question, because when I use GFC and find it, since we are talking of nutraceuticals up to stage 1 and 2, then and we feel that 3 and 4 it doesn't help. So there is something we have to think of it. And that is why I asked, we need some sort of a study to.
Wait, what is it?
I'm just going back.
It's a growth factor.
In fact, they have a kit in which they have platelet activators. As soon as the blood is taken into the kit, the platelets get activated, they release the growth factors. So there's hardly any cellular content in the injection which you give. So the likelihood of a reaction is much lesser. And I have been doing it. And over the last 4 years since I've been doing it, I've got great response from my patient, almost 90% feedback.
But part of it may be that those growth factors are analgesic.
Well, whatever the reason, I'm saying.
So I have a small comment to make as far as the PRP is concerned. I'm using it for last 8 to 10 years, and I have patients follow for more than 7 years, and who have come to me now after 7 years for PRP at other sites, for other lesions. They say they have no knee pain, they are functioning normally. But now they have come back for some other lesions.
Thank you, sir. We move on to Chennai now. Request you to please unmute yourself and ask your question. Chennai. Please go ahead. Be a bit louder, please. You are on mute. Okay.
Rheumatologists use biologicals much more.
That's correct.
Probably much more remunerative than PRP.
Not, I don't make any money.
Yeah, go ahead, please, Chennai. We can hear you now. Please be a bit louder.
This is Chennai. We are southern part of India. So a lot of patients in our part or most of them are vegetarian. So some of the companies here claim that they are sourcing collagen as a vegetarian source. So as a researcher, you do you think possible whether collagen can be taken from a vegetarian source? Because most of them when we prescribe any collagen UC2, they see the red mark there and go change to the pharmacist as a green mark. We are surprised to see those things. So as a researcher, do you have any inputs on this? Or?
Maybe I'll rephrase the question. So he's asking, can collagen be a vegetarian source?
I don't know. I don't, you mean, can you get collagens from
Well, he
plants?
specifically said that there are some pharmaceutical companies who are promoting collagen from vegetarian sources, and I have heard of that.
Yeah.
So that was his question.
So maybe my understanding.
I think Nancy,
sir,
I think the understanding is collagen is a source from the articular, the cartilage
Yes.
content. You cannot generate the source from a non-animal source.
Yeah, it could be that it is a polypeptide.
True, it's a
which they are like
And I think you
propagating
can
as
there are
collagen.
plant collagens, but it's different. Just
Yes.
Yes,
different.
yeah. The type 2 collagen.
Correct.
Any other question from Chennai before we move on to the next location? Okay, none.
One more question.
Yeah, go ahead, please.
Yes,
Chennai, go ahead.
Sundaram Medical Foundation. To the degree of
Sir, please be a bit louder. We
osteochondritis.
can't hear you.
Do we have any evidence of treating this recently booming osteochondritis dissecans (OCDs) in the regular practice in treating with UC2 molecules? Do we have any evidence currently to certain stages like grade 1, grade 2 osteochondritis dissecans?
So the question really is, if you have a flap of cartilage with a bone which is peeled off in a relatively younger patient,
Yeah,
who's got
younger patient, more common in sports injuries.
Sorry.
Yeah, relatively younger patients, more common in sports
Is there
injuries.
any role of adding a UC2 in that category of patient who's got a piece of articular cartilage and bone? The problem is it's a very, very specific question and it's very specific to disease. So you need a cohort of patients with an osteochondral lesion and then try and see. But that's a lot of variables in the theme. So you need a huge subset of patients. The cohort will be somewhere in the vicinity of 5,000 to 6,000 patients or something to show that actually that osteochondral lesion heals on itself, provided and then it works. But as I see it, Nancy, so osteochondral disease, a lesion kind of a stuff is either traumatic or it's idiopathic. The traumatic ones are obviously a different subset and you need to go and fix the fragment and all. The idiopathic ones are the ones where the disease is much more subchondral. So it's a bone which is actually failing you because of which the cartilage separates with the piece of bone. The chances that just working on the collagen in the cartilage will change the course of the disease may be wrong.
That's correct. I think the piece, that's a wonderful explanation. And I think the way I sort this is that UC2 has some anti-inflammatory action that works a little differently than the other anti-inflammatories we use. So if the osteochondral defect is causing some inflammation, then maybe it would be useful, but it's not going to help the abnormality.
Okay, so we move on to the next location, which is Kanpur. Please quickly unmute yourself and feel free to ask your question. So a couple of more locations left. Kanpur, please unmute yourself and ask your questions. Okay, yeah, maybe Ranchi or Bhubaneswar, just unmute yourself and please ask. We'll come back to Kanpur later. Ranchi, Bhubaneswar.
While we're waiting, Nancy, tell me, is glucosamine, sorry, as soon as they come, I'll just shut up. Glucosamine chondroitin, it's still selling. I can tell you all the kids who want to show love to their parents in India and live in the United States, all the best thing they do is buy those big jars of glucosamine. Is it a dead market in United States, or is the sales of glucosamine chondroitin still increasing?
Another great question. Let's see, how do I put it? If you believe the scientific evidence doesn't mean anything. So it's still selling, and people are still taking it. And what I say to my patients who ask me about it, I say, well, the studies don't really give me confidence, but if you want to take it, go ahead, take it for 3 months and then stop it for a couple months and see if things change. If it helps you, then take it. But do we prescribe it? No.
Tell me sorry, if they're ready, I'll.
Yes, sir. You can go ahead. I don't see anyone.
Tell me the trends in the US market right now. So we have, if you're going to compare the graph. So one stage is the glucosamine chondroitin, the second is the collagen, the third is the regenerative biology, which is PRP, stem cells and all. Fourth is hyaluronic acid. So what is the trend? Where is the curve going in the US market?
It's a really great question, how we treat, moderately severe or moderate knee-OA, I guess, with pain. It really depends on the patient's philosophies and the physician that they see. I'm a rheumatologist, someone comes to me with mild to moderate knee-OA that, maybe their joint's a little swollen, I'm probably going to give them an injection because they got to me. They had to go to their primary care first. So they got to me, at which point I may give them a steroid injection. I said, it's going to help you for a little while and this may come back. And then we kind of go down the path of how they want to treat it. And many patients will say, well, how about this glucosamine, about this UC2? And I tell them, I say, glucosamine works for some people, but didn't work when we studied it, and so we kind of work things out. There are many older adults in the United States that take nutraceuticals, and they take them no matter what I say as a physician. I think hyaluronic acid is used more by orthopedists probably than rheumatologists. I think rheumatologists do a lot more steroid injections. I think that there are stem cell injections that are being done in the United States for painful knee-OA, mostly done by orthopedists, not rheumatologists. And there's another group of doctors in the United States, and I don't know if you have this subspecialty over here. We call it physical medicine and rehab, PM&R. And they are like sports medicine doctors that don't go to the OR, and they give a lot of injections. So it depends where you land.
So effectively, Nancy, would you agree that even in the US, there are no fixed protocols for managing stage 2 osteoarthritis? It's as per the whims and fancies of the physician. Do you agree?
That's exactly right. And, like, for example, in the next year, we'll be writing the American College of Rheumatology recommendations for the treatment of osteoarthritis of the knee, hip, and hand.
But they're not binding.
That's right. And the International Osteoarthritis Society, ORSI, going to do another set too, and they're not binding. What they do is what guidelines do in the United States is they give me a framework, a broad framework. And when patients or lawyers challenge me about what I do, I'm supported by those professional guidelines. But in terms of diseases, what was my second slide after my introduction? A disease in which we don't have a cure, we do many things. We first do no harm, and we try to find comfort for the patient.
As you said, within the rheumatologists, the orthopedic surgeons, and the PMR, they have a different way of approaching the same condition, right?
And there's a lot of doctor shopping. For those that can afford it in the United States, there's a lot of doctor shopping. So I get patients that have had very interesting treatments that they found, someone to give them.
So from the other location, I think we got covered, the question got covered during the discussion. So if we have any other in the hall, okay. Yeah, please, ma'am, please go ahead.
Okay, I'm Dr. Meenakshi from Rohini. I'm a gynecologist. I am also getting few patients in geriatric population with so much of osteoarthritis and associated problems also, like obesity is the most common, and that puts a lot of efforts on the knees. So because we have to manage gynaec problem also, and along with this thing, osteoarthritis. So this molecule UC2 can be used for how long? If the patient is starting this molecule, for how long she can take treatment along with other medications also, like physiotherapy and other things which we advise.
Okay, I think there's a couple of questions in that. The
Yeah.
first thing, if they take UC2 and they find that it's helpful, they can take it for years. You can add to it because a lot of patients with NEOA will have mild to moderate NEOA. We'll have situations where they went out for a hike or something and they have pain, more acute pain. You can give them a steroid injection, topical NSAIDs, or oral NSAIDs for a few days and continue the UC2 if it's been found to help them. Is that helpful? Yeah.
I think that's what Meenakshi is raising is a fairly good subset of patients that we see, and I'm sure Anmol sees it in his. This is that post-menopausal woman who's reached about that 48 to 55 kind of an age group. They've hit menopause, and a lot of them come with the joint pains and everything. What's your prescription for these ladies? They suddenly feel that the joints are getting very stiff. When they get up in the morning, they have a difficulty getting going and everything. Do you place this as something that can fit into their treatment algorithm?
It's a little bit complicated, but the answer is yes. And the other answer is that subset of perimenopausal, postmenopausal women, sometimes some of that diffuse pain can be improved with very low dose estrogen replacement. You still with me? Okay.
It's also the time when they put on a bit of weight. So weight loss will help in a big way.
Yes, in the United States, we're dealing with that with a very expensive medications called the GLP-1 or the GI-1
We're selling it. We're selling it like big truckloads.
Yeah.
So yeah, just
please go
one
ahead, sir.
That was a great question, by the way. That was good.
Yeah, so Ashim Gupta here. So I was in the US for over a decade. So what Dr. Bedi was saying, so yes, UC2 is actually available over the counter. A lot of people just get it from Sam's Club, Costco. So question here is like the field of regen med is evolving. I know Dr. Anmol uses a lot of GFC. When we talk about PRP2, there's like first pro-inflammatory phase followed by anti-inflammation. So do you think UC2 can be coupled with PRP? Like somebody has PRP injection, let the pro-inflammatory phase calm down. Once anti-inflammation starts after a week or so, then couple it with UC2 therapy. So activated Tregs like secrete more IL-4, IL-10, TGF-beta and suppress pro-inflammatory cytokines. That's when you think it's going to be more beneficial?
I think the concept these days is very much multimodal. You're not going to depend on any one thing. If you're doing your PRP or your GFC and you want to add a UC2 later, great. In addition to, of course, the weight reductions, building up the quadriceps, avoiding stairs, avoiding squatting, having well-cushioned footwear. So it's always multimodal. You cannot bank on one therapy alone in a condition like osteoarthritis, where there's a major role of lifestyle modification also. Of course, pharmaceutical has its role. Injections, depending on your conviction, has its own role. But you cannot depend on one modality alone.
So say if you're doing it like based on your experience, you have to do it with say PRP or GFC. So would you start UC2 like straight away with the regenerate therapy, or you'll actually wait a week or 2 weeks and then
Oh,
start
I
using
get where you're going. UC2, if you remember a few of my slides, we have to bring it back up. It takes a while for it to work. I've never seen it work overnight. It takes a month or two. So yeah, you can start it before you give PRP, steroids, go from there. Don't worry about, it's not an acute effect, so you're not gonna like lose its effect. It takes a while to work, so then you can add another therapy if necessary to make them more comfortable in the interim time. That would be a very good study, by the way, to say, to start UC2 and then give, say, PRP and see how those patients do.
And the only question in your mind would be, what is working eventually?
We may never know.
We may never know.
Yes, sir. Please go ahead.
Hello, I'm Dr. Arjunopal. I'm a consultant orthopedics. My question is, since we have established that UC2 has little or no role in type 2 and type 3, grade 2 and grade 3 OA, and in grade 1 and 2, patients find it very difficult to reach their doctors. So can we give this medication as a prophylactic drug after a certain age group or in certain high-risk patients?
Prophylactic drug in a early stage arthritis where there are very few things. Is this good as a prophylaxis rather than a therapeutic indication?
Oh, yes, I would go with it for sure, with the caveat, we don't have any data that it would slow the course of the disease, okay? So if somebody comes in and says, like I have patients that come in and say, I've got this terrible history of osteoarthritis, what can I do to prevent it? They want to take UC2? I say, fine, okay? But I don't know if I'm going to reduce the severity of the disease when it becomes of onset. I don't know. But I do have one thought. If you have a knee, one normal knee and one knee with some pain, well, it wouldn't hurt to take it, but we don't have data.
Well, so in this audience, we have more than 100 plus people. Would you recommend them to take it?
No.
Sorry
if I ask awkward questions.
It's simple. You have to keep life simple. So
the common thing is the attendant question. So, you do one operation or knee replacement for the mother, and the second question comes from the son or the daughter. Doc, what should I be doing now? I think the answer to that is physical therapy, weight reduction, and everything. Wait for some specific symptoms to come back. But if you're getting very tired at a dinner party and you've got this person who keeps on hankering about you, oh doc, what are you advising me for my occasional knee pain? The quickest way to shut the discussion is take a Centrum joint. Sorry,
that's right.
I'm being very commercial about
I
this.
completely agree.
So a thought which just came to my mind, it just came to my mind that if the organizers could have a repeat meeting after a gap of maybe 18 months with the same audience and maybe the same speakers, and then say, okay, now what's your experience? Probably that would answer many of the questions which have been posed today.
For sure, sir. Just to answer this, aspect, we actually are also trying to run a study with the formulation with the orthopedicians in terms of, what is their experience with use of this brand. So we probably will also have that data by that time, and we can, look at the real answers as well.
So
Hi, ma'am.
myself, Dr. Rupali, consultant orthopedic surgeon. Do we have a role of UC2 in chondromalacia patella?
Is there a role of UC2 in chondromalacia patella?
Each stages.
Yeah, I'll make a comment on that. I think that the gym knee that I talked about is chondromalacia, and I think that it looks to be like it has some efficacy in that group. Now, the severity of it, that comes also in different flavors of severity. And so the real severe chondromalacia, no, but the more mild discomfort, I think it probably does have some efficacy. Exactly.
So in the later stages like grade 2 and 3, can we combine UC2 with GFC for better results?
Combination with physical therapy, yeah.
No, with GFC. GFC. Anmol, you're the torchbearer.
Guys,
Sir has been wanting to ask a question.
I'm Dr. Vivek. I'm orthopedic surgeon. I just wanted to know, some companies are promoting UC2 to be taken empty stomach in the morning, and some are saying it should be taken post-meal. What's your recommendation?
Oh, taking both or taking?
No, UC2
before meal.
So the question is, Does it have food interaction? Does it need to be taken empty stomach?
No, it doesn't have to be taken on an empty stomach. I probably take UC2 or the Centrum with some food in your stomach because there's some calcium in there, and I think it's digested a little
Because
bit better.
this has a calcium, some doesn't have a calcium. That's what I wanted to know. Is it supposed to be taken empty, or you will prefer it to post meal?
So if it is only UC2 without combination, then does that preference change? That you need to take it empty stomach?
No, but I think you just need to take it regularly. So whatever works out, if it, you remember after dinner, fine. I mean, I don't think there's anything to suggest that absorption changes, whether it's your stomach is before you eat or otherwise. And you're going to be taking it. It's not like a bisphosphonate like Fosamax where you take it once a week on, drink a cup of water on an empty stomach. You take this every day. So the absorption doesn't have to be all at once and for you to get efficacy.
Okay, maybe last couple of questions before we.
Any pleiotropic effects of UC2, like helping the cartilage degeneration, other effects on the body, like skeletal system and.
Oh, it's a great question. I don't know. I don't know that it's been studied well. But theoretically, if you've got a little bit of inflammation in other joints, it might be useful. But that would be a very good study to do in your office.
I want to. Cartilage doesn't matter. The looks matter. Does it help my skin? Does it help my hair? Tell me those things. I need to look smarter. The knee, nobody's going to see inside.
Many gray areas still.
Many gray areas.
I just wanted to tell the company that primary physicians like us see grade 1, grade 2 more than the orthopedic surgeons. So,
yeah, we agree, sir. We completely agree. Okay, maybe. Yeah, sir. Any last question before we move for our lunch? Because the question is only between us and the lunch. No.
Probably it's just a small comment. People don't take even prophylactic statins. What to say about collagen? And secondly, as you said, the role is anti-inflammatory. It stimulates the cells to reduce inflammation. When we talk of prophylaxis, it means there is no joint damage as yet. So it just doesn't make any sense.
Well, it doesn't make sense, but I would also say as a rheumatologist that there's probably inflammation that is what we'll call subclinical or before they get pain. I know there is, it's just a matter because actually when it comes to pain, say in the knee, you need the bone growth and the osteophytes is what bring the nerves in. And then you have to have inflammation in the synovium to bring the nociceptors in there. So there's a fair amount of damage. Some people don't get, pain until there's a lot of joint damage. So this prophylactics it's a little bit of a broad statement. The point is UC2, if you have evidence of mild disease or you have pain, there's enough evidence to suggest that it could be used. I guess I would say I would take more of a nuance and say it prevents, if you will, prophylaxis against maybe worse pain or worse disease. We don't know.
So the frank answer is the patient has come with a problem. Something has initiated the process for which I don't know the right answer to the question, but there is a reason why the patient has come. Patients don't walk in without a reason. Patients do not take a medicine for no reasons. So there is, if he's convinced enough, if he has a problem enough, he will take a medicine. But statin is a very, very classical thing. We try very, very hard to push the statins in. And again, people don't understand the consequences till they get a heart attack.
But I understand that for a minute, because in rheumatoid arthritis, we have this measurement now, anti-citrulated antibody. And you can get that picked up on different lab tests, and the patient doesn't have any pain in their joints, but they've got a positive rheumatoid factor and a citrulated antibody. Should I give them methotrexate? Some people do, some people don't. You get an x-ray by accident, you see there's NeoWave, but they don't have pain. Well, you can talk, we usually wait for a symptom.
Exactly. That's what we were taught. Diagnosis of rheumatoid arthritis is a clinical diagnosis, not a lab diagnosis.
Okay, so I think thank you so much. We are done with the question and answer. You have been a wonderful audience, a pack house on a Sunday. So thank you for coming in. Thank you for participating. Of course, the chairperson and Dr. Nancy, she has been traveling with us for last 3 days. This is the fourth day we have been hopping from a city to another. So thank you, especially Dr. Nancy. Thank you, Dr. Bedi, and thank you, sir, Dr. Maria. So just a token of thanks and appreciation from our end. Please. So, Dr. Bedi first. So thank you, sir. Thank you for running the show. Thank you for guiding us. Yeah. Thank you, all of you. You can join us for lunch.
Hi, hello. I would request the complete HALEON team to come on the stage, please, for a group photograph. Everyone from HALEON are requested to come here, please.
करता करता तो तुम ही हो
You earned it. You earned it.